Therapeutic Hypothermia and Cardiac Arrest by Heather Burkett and Suanne McGrory. Learning objectives for therapeutic hypothermia and cardiac arrest. After this presentation, the learner should be able to define therapeutic hypothermia, identify how patients are selected for induced therapeutic hypothermia, describe the 3 phases of induced therapeutic hypothermia and the nurse's responsibilities during these phases. Explain the goals of induced therapeutic hypothermia after cardiac arrest. Identify ways to educate and support family members during induced therapeutic hypothermia. The definition of therapeutic hypothermia. Therapeutic hypothermia is a medical treatment that lowers a patient's core temperature in order to decrease the risk of ischemia to the tissues of the body after cardiac arrest has occurred. There are 2 main ways of performing therapeutic hypothermia: invasive treatment and non-invasive treatment. Invasive treatment is to place a catheter in the inferior vena cava via the femoral vein. The femoral hypothermia catheter is placed, usually in the emergency department, by an attending physician. The ED nursing staff infuses iced normal saline via peripheral access and then notifies the ICU staff to prepare the equipment needed to begin the cooling phase upon arrival to the unit. Before the patient is transported to the ICU, a CT scan of the head must be performed to rule out a bleed. The non-invasive treatment usually involves a water vest and extremity wraps that have direct contact with patient's skin and are hooked to a cooling machine. In emergent situations, filling ice bags and placing them around the patient have also been utilized. Identifying patients for therapeutic hypothermia. Patients that are inclusive to receive this treatment will have a non-traumatic cardiac arrest with return of spontaneous circulation, CPR initiated within 10 minutes of cardiac arrest, return of spontaneous circulation within 30 minutes of recognition of the cardiac arrest, with a MAP greater than 60 for at least 30 minutes post return of spontaneous circulation, with or without vasoactive medication. Initiation of induced hypothermia begun within 6 hours of collapse. Initial body temperature must be greater than 30 degrees Celsius. No purposeful movement to command, and a Glasgow coma scale less than 6. They also must be greater than the age of 18, and females less than 50 must have a negative urine HCG. Patients that will be excluded from receiving this treatment include prolonged arrest time longer than 60 minutes or downtime without BLS longer than 10 minutes, age less than 18 years, pregnancy, uncontrolled bleeding, thrombocytopenia, or other coagulopathy, a DNR or DNI status, severely impaired pre-arrest cognitive status, other causes of coma, such as mass lesions, metabolic coma, drug overdose, head trauma, cerebrovascular accident. Continued exclusions per protocol. Patients with existing multi-organ dysfunction syndrome, severe sepsis, or comorbidities with minimal chance of meaningful survival independent of neurological status, or have a known terminal illness. Continue with refractory arrhythmias, are hypoxic with saturations less than 85% for more than 15 minutes. Response to verbal command after return of spontaneous circulation. The three phases of therapeutic hypothermia. The first phase is the cooling phase. In most centers, the patient is actively cooled by using an induced hypothermia protocol for 24 hours to a goal temperature of 32 to 34 degrees Celsius. The goal is to achieve the target temperature as quickly as possible. In most cases, this can be achieved within 3 to 4 hours of initiating cooling. The second phase is the maintenance phase. During the maintenance phase, controlling the patient's temperature within the target range is crucial. This phase can last up to 24 hours from the time the target temperature is reached, depending on facility protocols. The third phase is the rewarming phase. Temperature control remains important during rewarming. Warming the patient too quickly or allowing continued shivering causes dangerous electrolyte shifts, leading to potentially lethal arrhythmias. Controlled rewarming is recommended. To maintain tight temperature control throughout the rewarming, our protocol calls for neuromuscular blockade. Because electrolytes shift out of the cells back into the serum during rewarming, frequent electrolyte monitoring is needed during this phase to prevent critically elevated levels. Slow, controlled rewarming allows the kidneys to excrete excessive potassium, preventing hyperkalemia. The patient also may become hypoglycemic during rewarming as the insulin resistance of earlier hypothermia phases diminishes. Glucose levels must be monitored frequently, with insulin titration and dextrose boluses used as needed to maintain the patient within ordered ranges. Careful fluid monitoring during rewarming is crucial because of the vasodilation that accompanies a body temperature rise. Volume replacement may be needed to prevent fluid deficit and hypotension. The nurse's responsibilities during therapeutic hypothermia. Target cooling temperature must be achieved within 3 to 4 hours maximum. So nurses must be responsible for administering medication when shivering occurs. Shivering must be eliminated during the cooling process. Electrolytes and coagulation studies must be monitored during all phases of the hypothermia protocol, so the nurse is responsible for frequent blood draws. Complications of therapeutic hypothermia. Shivering during cooling leads to warming and will increase overall oxygen consumption. Shivering should be prevented by use of a neuromuscular blocker and also sedation. The incidence of complications such as arrhythmias, infection, and coagulopathy is likely to increase if the core temperature falls considerably below 32 degrees Celsius. Goals of therapeutic hypothermia. To improve mortality and neurological outcomes in patients who have survived cardiac arrest. The goal of therapy is to achieve and maintain therapeutic hypothermia for a 24-hour period with a target temperature of 33 degrees Celsius. Family support in therapeutic hypothermia. Be sure to provide family support and education. Cardiac arrest occurs suddenly and usually without any warning. Family members may be overwhelmed by the thought that their loved one is critically ill and attached to machines, as well as the amount of activity and clinicians involved in the patient's care. To reduce their anxiety, explain the equipment, tests, monitoring, and procedures. They may express concern that their loved one is cold to touch. Teach them the reasons for the therapeutic hypothermia and how long it will last. Reassure them that sedation and analgesics are being used to ease patient discomfort. Advise them that therapeutic hypothermia can improve outcomes after cardiac arrest. Explain that the goal is for the patient to emerge from therapeutic hypothermia neurologically intact without complications of a critical illness. These are just a few pictures of our hypothermia machine. The picture on the left-hand side shows the machine with the lid up, with the coil and all the tubing that we need to set up, that nurses set up in the ICU when we know that a patient's coming from the emergency room. The pictures to the right show the screen to the hypothermia machine. You can see the dials, and that's how we set the machine to pick the temperature that we need to be. And the picture on the right, the right hand on the bottom, shows the screen, and it shows that the temperature we set in Fahrenheit is 91.4 is our goal temperature. Thank you for listening to our presentation. If you would please take our survey. Thank you very much.